Hello, everyone, and thank you for joining us at the 12th Annual Joining Forces Against Hereditary Cancer Conference on National Previvor Day of National Hereditary Cancer Week. We are so happy that you are all here with us today virtually. We have over 2,000 registrants for this conference, and currently there are 650 of us online right now accessing sessions, resources, having conversations in the networking lounge, and speaking with sponsors in our exhibitor hall. So a very robust conference. So we thank you all for your efforts and your attendance here today to make this a wonderfully impactful conference. Thank you for joining us specifically for this panel, Targeted Therapies and Immunotherapies. The topics that we will cover today are paramount to our community. The power of force improves the lives of millions of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with a BRCA, ATM, PALB2, CHEK2, and other inherited gene mutations, and those diagnosed with Lynch syndrome. The FORCE mission is accomplished through education, support, advocacy, and research efforts. During and after the conference, be sure to visit the FORCE resource page, exhibit booth, and the FORCE website for expert-reviewed information and access to support groups, including our virtual Zoom meetings, peer navigation matching program, and online message boards. Our FORCE volunteers and FORCE staff additionally are in the networking lounge and at our exhibit booth waiting to answer your questions and have conversations with you. So please head to both of those places before the end of today. At this time, I would like to introduce our panelists. Our first panelist is Dr. Michael Hall. He is a GI oncologist and clinical care geneticist at Fox Chase Cancer Center. He is chair of the Department of Clinical Genetics and serves as the director of gastrointestinal risk assessment. Please view his conference session, What's New in Colorectal Cancer Treatment, today at 2 p.m. Our next panelist is Dr. Melinda Telli. She is the Associate Professor in Medicine at the Stanford University School of Medicine, with a focus in breast cancer medical oncology. Dr. Telli serves as the Director of the Breast Cancer Program at the Stanford Cancer Institute and Associate Director of the Stanford Women's Cancer Center. Dr. Telli is a clinical researcher with expertise in novel therapeutics for triple-negative and in hereditary breast cancer. You can go back and review her presentation from earlier today, What's New in Breast Cancer Treatment. We will also be answering some of the questions from that presentation in this panel as well. And our last panelist is Dr. Ryan Kahn. He is a gynecological oncology fellow at Memorial Sloan Kettering Cancer Center in New York City. Dr. Kahn completed his undergraduate studies and master's degree at Johns Hopkins University and graduated with research distinction from the University of Miami. His residence was completed in obstetrics and gynecology at New York Presbyterian, Weill Cornell Medical School in New York City. Dr. Kahn's research includes interests in clinical genetics, cascade genetic testing, ovarian cancer immunology, minimally invasive surgery, and surgical outcomes. If you look on the individual session resource tab for this session, you will find access to cascade testing resources for providers and patients that Dr. Kahn is working on. It's called cascaderesources.net. Please be sure to go and visit that site. At this time, please type all of your questions into the chat. We will try to get through as many as we can, but as noted, we have a lot of attendees here today with a lot of questions, a lot of thoughtful questions. So we will try to get through them all, and if we do not, we will follow up. So let's get started. The overarching question that we really have for this session, and it's come up multiple times, and I'm sure it will come up in the chat, are constituents who are wondering, are PARP inhibitors right for me? Are they right if I have a BRCA1 mutation with breast cancer? Are they right if I have a CHEK2 mutation and I have colorectal cancer? So I'm going to ask all of our panelists here today to speak just a little bit to the use of PARP inhibitors specific to your specialties. Dr. Hall, can you please go first?
Sure. So I think, the best answer to that question is maybe, which I know is a non-committal answer. I think in GI oncology, which is my area of expertise, certainly the data are strongest for PARP inhibitor use in the setting of pancreatic cancer, pancreatic adenocarcinoma, and that's metastatic pancreatic adenocarcinoma. And those data come from a large study called the POLO trial that was completed a couple years ago now. And what that trial looked at were patients with metastatic pancreas cancer who were found on an initial chemotherapy run-in period of at least 16 weeks, but it could have been longer, but at least 16 weeks of response to platinum-based therapy. And as long as patients were shown, patients who were carriers of BRCA1 or BRCA2 mutations, I want to make sure that's clear. So you had to be someone who was a known mutation carrier to get on this study. And as long as then you had response to platinum-based therapy for at least 16 weeks, then you were eligible to be randomized to either PARP inhibitor or placebo in a maintenance setting. And what was seen on that trial was pretty impressive, particularly extended stable disease and progression-free survival in patients who were randomized to the PARP inhibitor arm. Now, there were many people who progressed, and even patients who were, clearly responders on the platinum-based therapy. This is far from being sort of a perfect targeted therapy, but there were enough responders on the PARP inhibitor arm who some of them had responses, again, beyond even 2 years of response on PARP inhibitor therapy, which is basically unheard of otherwise in pancreas cancer treatment. So I would say that the first question for any patient thinking about this is, do I have the right disease? And pancreas is where we have the most data. I'll talk in a minute just a little bit about colon. But then, do I have, again, the right sort of molecular target? Again, mostly we're focused on germline mutation carriers right now, although there are data that are emerging that perhaps if you have the mutation in BRCA or perhaps as well PALB2 or ATM in your tumor, that may also be relevant. But right now the approval is for germline mutation carriers, BRCA1 and 2 with pancreas cancer who are responsive to platinum-based therapy for at least 16 weeks. I'll let the others speak, so I don't want to take up too much time, but in colon, we are testing PARP inhibitors right now, particularly in tumors that have mutations in homologous recombination deficient genes, such as ATM or such as the BRCA genes. I'll say that right now, the data are still uncertain as to whether we'll see PARP inhibitors as having a significant benefit in that group. But the future is bright, and we'll see how the trials come out. Maybe it'll be a combination therapy that'll actually work out, perhaps especially PARP inhibitor combined with immunotherapy, but we'll have to see.
Excellent, thank you. Dr. Telli, can you speak to your field?
Yeah, sure. I think for us, we have had PARP inhibitors approved for use in breast cancer. So if we go back, our first approval came in 2018, the approval of olaparib for metastatic breast cancer, either triple negative or hormone receptor positive, HER2 negative, associated with, again, a germline or inherited mutation in BRCA1 or BRCA2. And shortly thereafter, we saw a very similar study reported looking at talazoparib in the same patient population, metastatic HER2 negative breast cancer. And so we had talazoparib approved. We have been in breast cancer probing beyond BRCA in the advanced disease setting, certainly. We have not moved that field forward as much as, say, in ovarian cancer. But certainly there's ongoing studies looking at the role of PARP inhibitors beyond BRCA for metastatic breast cancer patients. I think at this point in time, our strongest signals for breast cancer, at least, have been for those carriers of PALB2 mutations. There have been some small series, including one from our institution, reporting high rates of response just with a PARP inhibitor alone in metastatic PALB2 associated breast cancer. And there has also been some data looking at the response with PARP inhibitors for those tumors with somatic mutations. So the patient doesn't have an inherited form of BRCA1 or BRCA2 alteration, but their tumor nonetheless has it. And so while the drugs aren't approved for that in the advanced setting now, there's more and more data accumulating. I think in breast cancer, and I spent a lot of time in my session this morning talking about it, but we've had a huge advance this year. And this was the move with PARP inhibitors into the early phase setting, into the adjuvant setting. So this was the incredible study. It was an incredible feat pulling this off. But Olympia was the main talk at the American Society of Clinical Oncology meeting this past summer. And this was a phase 3 trial looking at patients with HER2-negative breast cancer early stage who completed all of their standard treatment, standard chemotherapy, surgery, radiation if it was indicated. And then they were randomized to receive 1 year of olaparib. So just the standard dosing twice daily for 1 year, or a placebo. And then the patients were followed for recurrence and for survival. And so what we found in that study that enrolled, again, worldwide, over 1,800 patients. So incredible study in that was successful. We successfully recruited and enrolled all those patients, but it showed clearly an advantage for survival free of disease, so of invasive breast cancer. And we very importantly saw improvement in distant recurrence. So fewer patients had a distant recurrence if they received olaparib compared to the standard treatment. And we are waiting for the final overall survival data from that trial to mature. Patients are still being followed. And so the results are still blinded, but definitely that is a practice-changing result. We were very, very pleased to see that the safety looked excellent. There was no increase in any of the toxicities of interest related to the bone marrow, so MDS or acute leukemia. And the other really provocative thing that we saw in Olympia was that patients who received the olaparib had fewer other cancers diagnosed in that follow-up period so far. So suggesting that there probably is a prevention effect. So we saw fewer ovarian fallopian tube cancers, fewer other, non-breast, non-GYN cancers in this group of patients. So I think we've always sort of felt, yes, PARP inhibitors have a role in prevention. And this was sort of our first big data showing that patients were having fewer new cancers diagnosed who received olaparib. So incredibly important result. It is practice changing. And I think the other big thing in the early stage setting that's incredibly provocative, and there's going to be some follow-up studies, is just looking at PARP inhibitors given alone as monotherapy for the treatment of primary breast cancer. We have the NeoTALA trial that was also reported at ASCO, just talazoparib, 1 milligram, 1 pill a day, no chemotherapy, which would be the standard in triple negative breast cancer, stage 1 to 3, showing response rates very comparable to what we see with combination chemotherapy. So that's very provocative. Can we, in certain patients with BRCA mutations, just walk away from chemotherapy altogether? And so these are sort of the ongoing questions, right, that future trials will address. So it's been an exciting year for PARP inhibitors in breast cancer.
Yes, and I think it really speaks to the intelligence of our constituent space here, because so much of what you just mentioned were answers to questions that are being asked. For instance, what does the future look like for treatment or standard of care for metastatic breast cancer? Are PARP inhibitors effective for triple negative breast cancer? And I think you just so eloquently spoke through so many and answered so many of those questions for our constituent base. Dr. Kahn, can you please speak to specifically your area of specialty?
Absolutely. Thanks, Elise. And thanks for FORCE for having us here. I can't speak highly enough for what FORCE does with advocacy and helping our patients. So thank you for all that you do. So like Dr. Hall said, I think one of the easiest answers is, it depends. It definitely depends on the patient. And what an exciting time for GYN oncology. And we're learning more from our colleagues in breast and pancreatic and colon cancer when it comes to PARP inhibitors. So we date back to, I believe, December 2014 was one of the first FDA approvals for PARP inhibitors. I believe it was olaparib in ovarian cancers. So, about 7 years ago is when we received our first FDA approval, and it's the landscape's ever changing. Even month by month, year by year, we're seeing more and more FDA approvals for different tumor characteristics and for different patients. And in a very exciting time, we're seeing progression-free survival curves and Kaplan-Meier curves and survival curves like we've never seen before with PARP. So it's really changing the game for us on the GYN land front. So right now, most of the approvals for the three major ones we use in the GYN oncology realm are olaparib, niraparib, and rucaparib, all of which are different approvals based on the patients. But right now it's advanced stage, so stage 3 and stage 4, and for platinum sensitive or with a partial response to the initial platinum therapy. And that's what we're seeing for most of our patients. We do know in the GYN oncology realm, the patients that have the greatest effect and the greatest benefit from PARP inhibitors right now are BRCA1 and BRCA2 patients. That makes up about 15 to 18% of newly diagnosed ovarian cancers will have some germline mutation in BRCA1 and 2. About 30 to 33% will have something called homologous recombination deficiency, which we're able to send for testing outside of the germline testing of the tumor. So these patients also receive benefit. In some trials, we're seeing close to the benefit of BRCA1 and 2. So that makes up about 50% of the patient populations of ones that are approved either for olaparib in the maintenance setting. Niraparib actually has, they're approved in the maintenance setting regardless of HRD or BRCA wild type or mutation status, as well as olaparib with bevacizumab in BRCA and HRD aberrant population as well. So we're seeing different patient populations across the board. Also in the treatment phase, whether it's after your third or fourth recurrence, depending on the patient populations themselves. A lot of work that we're still doing. Dr. Pennington just gave an excellent talk, but one thing that we're really looking into now is re-challenging and retreatment with PARP inhibitors. If you have been on a PARP for several years and the cancer comes back or it becomes resistant, for whatever reason, are we able to retreat with PARP? And based on the most recent ESMO results in 2021, it was just presented about 2 weeks ago from the European Society, they are seeing a slight benefit in patients who are rechallenged with olaparib, who have been a BRCA1 and 2 mutation. So something we're definitely looking more towards into in that realm. Other things outside of just the medicine and the benefit, but a lot of my colleagues here at MSK, Dr. Gordon Das and Dr. Adiki, for instance, have been looking into financial toxicities with PARPs, and something that goes unnoticed a lot in physicians, but something that we still have a lot of room to make major improvements in is the cost effectiveness and toxicities that we see amongst our patients. So really identifying patients that are going to benefit from this and making sure that we're receiving it and advocating for them to receive it in a cost-effective manner.
I think that's really important. We do have a number of questions, of course, that come through about access to care and cost of care. So it's wonderful to hear that yourself and your colleagues are all tapped into that and that you are trying to make PARPs more available to the general community. I have a specific question that just came in from a constituent for you, Dr. Hall. And I think all of the panelists just spoke to the elaborate landscape of what is available to patients. So this particular constituent wants to know, with so many different immunotherapies and targeted therapies available for the treatment of metastatic colorectal cancer in a patient with, say, Lynch syndrome, how does a medical provider decide which treatment they are going to use first?
I think that is an excellent question. I'm going to focus on the metastatic setting, where I think we really have the best data that have, I think, raised this question, and I think we've learned something. And specifically, I'm going to focus on sort of that choice in someone who, let's say, for instance, has Lynch syndrome and would potentially, in the frontline metastatic setting, having a microsatellite high tumor, potentially have the choice of a targeted therapy like a pembrolizumab or a combination therapy, nivolumab and ipilimumab perhaps, although that's really approved in the second line setting, versus chemotherapy, traditional chemotherapy. And really our decision-making at that point is often just based on the pace of the disease and how the patient looks and feels sitting in front of us, in the chair at that first visit. One thing we have certainly learned, not just from the GI literature, but from trials, I think, across all of our disease sites, but GI is, I think, one particularly where disease that is behaving aggressively can really, if it's not sort of hit hard early on, really knock people down and even sometimes make them untreatable if you don't get control of the disease quickly. And so what we learned in the Keynote 177 trial, when we looked at the survival curves, is that actually in the first few months, chemotherapy did better than immunotherapy for some patients. And that's because there are just some patients with colon cancer, like all cancers, colon cancer is a spectrum. I see patients who sometimes walk in and you would never know they even had cancer if we didn't have a CAT scan that told us so. And then I have other people who are incredibly ill with fevers and night sweats and weight loss and other things. And so that clinical picture at presentation of either very aggressive looking disease that I need to really try to bring under control quickly. Sometimes that may be someone who frankly has a liver that's just chock full of metastatic disease. That's someone where I just don't have the time for an immune system to recognize a PD-1 or PD-L1 inhibitor, ramp up a response, and then start attacking the tumor. We really need to do something quickly. So in that setting, I would absolutely choose chemotherapy first because that can shrink disease quickly, bring symptoms under control, help people feel better, and then perhaps down the line we could transition to an immunotherapy. Whereas the patient who walks in off the street would otherwise not know they have, let's say, metastatic colon cancer, but they do happen to be MSI high either because of Lynch syndrome or a somatic methylation of the MLH1 promoter. That's someone who's a perfect candidate for immunotherapy. You can give them therapy. These days you can treat people every 6 weeks with immunotherapy, which is about as convenient, I think, as a lot of chemotherapies can get that you're still getting in the office. And these people can do incredibly, incredibly well. As we've seen in immunotherapy, although it's not everyone, there are some people who achieve something that essentially appears to be cure after some time. So again, if we can avoid chemotherapies, it's great, but there just still remain a subset of patients. And I would say in my practice, it's probably somewhere around 15% of patients where clearly chemotherapy is still going to initially at least be the best first choice that might then transition into an immunotherapy. I feel like there was a second part to the question that I may not have answered. But
I think that was actually a very thorough answer. And you said something that resonates so much, and that is when you look at your patient, how are they doing? And I think not only does that resonate for people when they're thinking about symptoms, it also resonates with our constituents when they're thinking about side effects. Yeah. And I'm wondering for you, Dr. Telli, and your patients, if you have a patient that is newer and is not as knowledgeable about PARP inhibitors, and they're worried about potential side effects compared to a traditional chemotherapy treatment, what do side effects look like for PARP inhibitors and immunotherapies?
Yeah, so I think in general, if we take the first comparison of a PARP inhibitor versus chemotherapy, I mean, it's quite a considerable difference in terms of the patient experience. With a PARP inhibitor, it's dosed orally, so patients are really saving a lot of time coming to the cancer center, spending time in the infusion room. And so there's just a lot of freedom that provides, that you don't have to be within a certain distance of your cancer clinic where you're getting your treatment. And so that's a big convenience factor. But I think in terms of quality of life, and we've seen this with the different studies that have been done, the big studies in metastatic breast cancer with PARP inhibitor versus chemotherapy, that certainly quality of life is superior for patients. And this is, these are questions that the patients answer in terms of their overall level of functioning, how well they're doing, and with different types of symptoms. And so we do see with a PARP inhibitor, sometimes when you first initiate, there can be nausea. It tends to resolve pretty quickly, but that's just something to know about, and to provide anti-nausea medicines in that initial period is needed. Many patients over time don't need those, and many people up front don't need them at all. The blood count lowering is certainly an issue. That's probably one of the more significant issues. There's some patients that, again, just will take a PARP inhibitor and have no trouble with their blood counts at all. And then there are others that will develop, seem to be, for whatever reason, their bone marrow is more sensitive, and we see drops in the blood counts. And it can vary a little bit with the different PARP inhibitors, some that may affect the platelets a little more, the red blood cells a little bit more. But we really can manage that pretty effectively with dose modification and things like that. Hair loss is an uncommon feature with PARP inhibition. Some drugs have reported some hair thinning, but total hair loss is really uncommon, where that's a much more common toxicity with chemotherapy. We don't see neuropathy, which is, again, common with many of our therapies in breast cancer. And so overall, the patient experience is really quite good. Patients, once they get established and we know that their blood counts are handling the dose well, they don't have to have as frequent appointments as our patients getting chemo.
Excellent. Thank you.
And then for the immunotherapy issue, in breast cancer, at least, in certain cancer types, we give immunotherapy alone. And so immunotherapy, compared to chemotherapy, is a very different experience. But in breast cancer, we have had increasing data and approvals for immunotherapy drugs in breast cancer, both in early and advanced breast cancer. But our approach in breast is to give it in combination. So patients aren't gaining a lot in terms of, having minimized chemotherapy side effects. So in breast cancer, when we give immunotherapy, we're giving it in combination with chemo.
Excellent. Thank you. And so the next question, Dr. Kahn, and this is a good segue from that when we're talking about administering medications together or combining treatments. When we're looking beyond PARP inhibitors, are there any new targeted therapies being developed that work similar to PARP inhibitors, or are a direct complement to PARP inhibitors?
Yeah, excellent question, and something that we're really targeting in the GYN oncology realm. So PARP inhibitors work, and I'm sure a lot of our constituents out there have seen a lot of the presentations throughout today. But polyadenosine ribose phosphorylase is an enzyme that helps with the repair of double-strand breaks of the DNA. So what we see in the GYN oncology realm is this synthetic lethality that's really effective for BRCA1 and 2 and homologous recombination deficiency patients. But basically, it doesn't allow these aberrant DNA damaged DNA cells to replicate themselves in a malignant fashion. So what we're looking at now is called something DDRs, or DNA damage repair systems. And there are so many different ways for DNA to repair themselves outside of just PARP, which is the enzyme that repairs it. So we're looking at different, different forms as well as different times in DNA replication. So things that I'm aware of, and I'm sure Dr. Hull and Dr. Telli, and so many different realms and so many things being studied now. But I know for us, DNA phosphorylase kinase is one, CHK1 and 2, or some other ones, WEE1, APE1, are all different forms and things you may hear along the lines, but all are still very early right now in ways that we're looking to target this DNA and stopping this aberrant replication. As far as combining PARP inhibitors with other medications, right now we recommend against combining with conventional chemotherapy, such as the carboplatin, paclitaxel, or taxane. We're using this more in the maintenance or recurrent setting. So we aren't combining with upfront chemo at this time. We don't have a lot of good data around that at this time, and we're not really sure of the effectiveness of that. We are combining olaparib has been approved with bevacizumab. in the maintenance setting for advanced stage 3 or stage 4, platinum sensitive for partial response to platinum disease that have been shown to have a BRCA mutation or an HRD component of the tumor. So this is a combination that works well. Avastin or bevacizumab being a VEGF inhibitor that we see works well in complement with PARP inhibitors. So we're still learning a lot. We don't know about this medication, why it may work well with some and not others. I think there are a lot more things coming down the pipeline in a very exciting time as we continue to target the DNA replication, seeing how we could control this in a pharmaceutical level.
Thank you. And so this is a question for all of you, one that often comes up with our constituents, and that is the interest in timelines. So typically, how long can someone remain on a PARP inhibitor? How long does someone have to stay on a PARP inhibitor in order to be deemed that it is working or it is having an impact on their cancer or their prognosis? If each of you could kind of speak to any specific timelines that you can give to our constituents in terms of treatment using PARP inhibitors and immunotherapies.
I can go first because probably the GI, the experience is the most limited. Probably Melinda or Dr. Telli has the most experience in this area, but I would say in GI, at least from POLO, the study again that looked at PARP in pancreatic cancer, I am not aware that there was any particular time limitation that folks could be on olaparib in that study. As actually Dr. Telli pointed out when she was speaking before, of course, there are side effects of PARP inhibitors, and particularly you do have to watch blood counts carefully, and there have been some reported marrow toxicity. So I think that is, from my standpoint, I think probably the thing that I would evaluate the most closely in someone who perhaps I had on PARP inhibitor for, again, in the pancreas trial, there were at least a handful of patients who were on PARPs up to 2 years plus. But they, that when we looked at toxicity data, the toxicity numbers were not particularly that different than the patients on placebo. So I think, as we heard from Dr. Telli before, I think this argues that these are drugs that perhaps people can be on long-term. Perhaps they may have some sort of prevention potential down the line. But I think, of course, they still have to have monitoring, and particularly the bone marrow toxicity.
Yeah, I can talk next. I mean, I think that we see a range of outcomes with PARP inhibitors, and I think it's a little bit different by, what is the tumor site, whether it's breast or ovarian or, pancreas or prostate. So while we all really love PARP inhibitors and think that they're great, certainly, the data and the experience that I have had with breast cancer, they can work really very well and lead to great responses. But the big problem that we do see in the clinic is this concept of resistance. So it can emerge with treatment. And so that is, for me, I think in the metastatic setting, the most challenging issue. If we look at different studies with PARP inhibitors, the median sort of period of time that patients are on these drugs is certainly less than a year. So while there are some patients whose tumors can remain very sensitive, we don't see this emergence of resistance, and they can be on these drugs for many years. The more typical experience is that a PARP inhibitor controls the cancer for a more limited period of time. And we're talking here about metastatic breast cancer, metastatic cancers generally. So like Dr. Kahn was discussing, I think this is why we're all very interested, PARP inhibitors. This was our first real proof of concept that we could, use a targeted therapy specifically in these hereditary breast cancers. We know what's wrong in the cancers that arise in the setting of BRCA1 and BRCA2. We've proven that we can target it with a PARP inhibitor, but we're only just beginning, right? So PARP inhibitors were our first therapeutic, and we do hope that we're going to be seeing more of these novel early in development agents moving forward for hereditary cancer. But a big thing is, are there combinations that can maybe help to delay this resistance? If resistance to a PARP inhibitor occurs, what is the best next treatment? So these are all really important questions for us. And I think probably, in the GYN oncology space, they've gone the furthest with this, with these questions of if you've had one PARP inhibitor and the cancer becomes active, can you switch to another PARP inhibitor? And, all of these types of questions that I think are really critical as we move forward.
Yeah, excellent question, and similar sentiments in our realm with GYN oncology, but we're still learning so much. And because patients are doing so well on PARPs and certain populations are doing so well, we're getting more and more data as we go. So Solo 1, which is one of the first trials, was initially designed for 24 months. Prima was initially designed for 36 months, and patients were doing very well. We saw from some of those that certain patients that received for the 2 years and didn't have a response within those 2 years, about more than half of those, about 50 to 55%, still had no recurrence at the 5-year mark. So we're currently looking at Solo 2 data, which is still currently ongoing and being presented at conferences. It was recently presented at ESMO last year, but that's been going on for greater than 8 years now. And we're really trying to find that risk benefit and how long do we need to keep patients on PARP inhibitors. There are some patients who are still receiving them off-label for longer because they are doing so well than those initial 2 and 3 years, just because we don't know what the optimum time is, and it may differ by patients. But we're learning more as we go, and our studies are underway to do so. But the exciting thing is that we are continuing these studies because these curves and these Kaplan-Meier curves are like we've never seen before for medications for advanced stage ovarian. So a very exciting time and something we're looking forward to learning more about.
Excellent. Thank you. All wonderful answers, incredibly thorough. And so for a lot of our constituents, this is an access to medications. They're interested in how they can get enrolled in clinical trials. I do, for a second, just want to say to those constituents, again, the Forest exhibit booth and the Forest website is a good place to start if you're looking for access to clinical trials and providers. Dr. Kahn, I did want to take this time to talk about genetic testing and how that impacts treatment down the road. And maybe you can speak a little bit about the project that you're working on with cascade testing, because so many of our attendees here today are starting at the very beginning. They're interested in immunotherapies and targeted therapies, but they're still trying to figure out what their screening processes and their risk reducing procedures will look like for their own mutations. So we could start a little bit at the beginning and just talk about cascade testing and how it impacts treatment.
Great. Yeah, thanks, Elise, and a great segue as well. So been very interested in cascade genetic testing. And what that means is if your family member, you yourself or a family member were found to have an actionable mutation, such as BRCA1 and BRCA2, for first-degree relatives, there's about a 50% chance that a first-degree relative will also harbor that same mutation, given that it is autosomal dominant. So there are many things, whether it's screening or risk reduction in surgeries or imaging, that could either decrease or significantly reduce your risk of future cancer. So it does great benefit for first-degree family members and second-degree family members to undergo testing, and something that we're trying to increase awareness about, because right now it's estimated about 85 to 90% of the United States population has an actionable mutation that we could do something about, yet most are unaware that there were even resources to access this. And we're talking about immunotherapies and PARP inhibitors, and we're making such great leaps in that realm of our management. Yet there's still such a large population that could benefit from preventing the disease in general. And I feel like that's what we're trying to tap into with our Cascade resources. So I received grant funding, me and my partners, Sushmita Gordon-Das, also a clinician here at MSK, and Dr. Melissa Frey, who's done a lot of work with Force in clinical genetics at Weill Cornell, we developed a website called Cascade Resources Network, or cascaderesources.net, and you could visit the link, I believe, in the resources tab, and we could send that out after as well. But it basically lists a lot of organizations and companies that do offer genetic testing, whether free of cost or reduced price based on the individual's risk, as well as genetic counseling resources, no matter where you are in the country. And this is even going as we get into this, unfortunately with the pandemic, but we are getting better and better at telehealth and telemedicine. And a lot of these genetic counseling visits can be done, via telemedicine now as well, which is a very exciting benefit for our patients as well. And the reason to do so, like I mentioned, a lot of people out there do have an increased risk that have yet to know about it. And there are a lot of things you could do, and whether it's preventing the cancer itself or informing family members undergoing risk-reducing surgery, such as a risk-reducing mastectomy, as well as a risk-reducing bilateral salpingo-oophorectomy, which is removal of the tubes in the ovaries for BRCA1, BRCA2, and other moderate penetrance genes. These have been shown to significantly reduce the risk of ovarian cancer in these patients. And then once you get into the realm of, God forbid, or knock on wood, if you are diagnosed with cancer, this could also lead to treatment options that could be available to you if you were to harbor one of these mutations. So both in the prevention and the treatment realm, it could do the patient's benefit, and something we definitely recommend.
Excellent. Thank you so much for sharing a great deal of background there. We do have time for just kind of one more topic or question here. We have about 2 minutes, and Dr. Hall shared with us before we jumped on today that he is actually in the middle of his busiest clinical day. So Dr. Hall, we would just like you to speak to a little bit about what you're seeing in the clinical environment now with your patients, anything that you would like to speak to in terms of trends, in terms of treatment, in terms of what your patients are saying in this current environment.
No, I think I feel fortunate that I practice in such a molecularly exciting time that we live in, to be able to take care of our patients with some of the incredible tools we have out there to have a new patient walk in and be able to send off a small piece of their tumor and a blood sample, and within a few weeks get an incredible molecular profile of course, we're still in our infancy of understanding a lot of the information that we get back, but nonetheless, to be able to translate that information. I'll give you sort of two examples of two women I saw consecutively today, both with pancreas cancer, both at relatively early ages, both of whom I would have guessed based on family history and otherwise that perhaps they had a hereditary BRCA mutation, because we've all learned that pancreas cancer is often caused by inherited BRCA mutations. But lo and behold, one had a rarer CDKN2A mutation, or P16, which led to a whole sort of different discussion with thankfully family members who were present with her. And, just a real lack of realization in the family that there were risks there. And when we started sort of exploring in the family, oh yeah, there was an uncle who had melanoma, and there were these other things that suddenly, woke everyone up. And several years ago, when we were still testing everyone one gene at a time, it may have taken us a while to get to this result. And suddenly with a panel test done right at the beginning to help us determine sort of therapy choices, and otherwise we had this information. So we're able to move the clock up. My other patient was a young woman who amazingly had breast cancer right before genetic testing sort of emerged as something we were able to do more commonly. But she'd had breast cancer at age 20, and we found that she had a P53 mutation, which does not usually cause pancreas cancer, or it's not one of our classic tumors that goes along with that. But nonetheless, we finding this is of incredible value to family members. We've had numerous family members who have come in. We've transmitted this information to them. And so I think our diagnostics, again, like I wanted to say, we're still in the infancy of understanding how to use them best. I think are opening up an enormous amount of information to us that I think will ultimately lead to great benefits for our patients.
Excellent. And we have some time. I wanted to end with you, Dr. Telli, because you were talking about what a big year it has been for the breast cancer community and the advancements that are being made. And I know that you just gave your talk prior to this one, and I want to know if there were any key takeaways that you thought were worth sharing with the rest of our constituents here who could not attend your talk earlier today.
Yeah, I mean, I think in terms of breast cancer, if we just, look at PARP inhibitors, it's really been great to see these drugs make the move from the metastatic setting now into the early disease setting. And I think, we have some clues from ovarian cancer as well, right? If we use a PARP inhibitor to treat really advanced established metastatic breast cancer, while we see benefit, it isn't, incredibly long lasting. If we move it earlier, like in ovarian cancer and this concept of maintenance, we see patients deriving greater benefit. And now the data that we have in breast, looking at moving it into the localized setting, right, before there's any established metastatic spread. I think if we look at all of that, data, certainly we're walking away with the conclusion that earlier is better. I do think there's a lot of promise, for other disease areas beyond breast cancer to really look at PARP inhibitors in the early curable stage. So I would predict that it's going to be a really exciting, 5 years ahead as we explore these things. Hopefully with such an engaged community with FORCE, we will have all of the support to enroll to these trials and really answer these important questions.
Thank you. I think that is a perfect place to end. Thank you to our panelists. Thank you to our sponsors for bringing this programming to you. Please continue to access all areas of the platform, and we look forward to seeing you in further sessions. Thank you so much, everyone. Have a good day.
Thank you.
Bye, everybody.